tonight we will have a discussion of the pregnancy and heart disease. Big problem because about 1 to 4% of patients of pregnant women, they have concomitant heart disease. And if you make simple calculation, في سنة 2019 عدد المواليد في مصر كان 2.3 مليون. So we have 2.3 million pregnancy. So if you make simple calculation, this amounts to almost 70,000 pregnant women with heart disease. If you add to that patients who are developing hypertension during a pregnancy, you multiply this figure by 3. So that's a huge number. So taking that in consideration, let us take a simple question just to get started. A 34-year-old woman presents for evaluation at the 32nd week of gestation for evaluation of a murmur. She has no history of cardiac disease, which physical examination finding is not normal. It's not normal finding during pregnancy. Mammary souffle, mild pedal edema, third heart sound gallop, jugular venous distension, or a diastolic murmur. The correct answer, you cannot get normally a diastolic murmur in pregnancy. You can get, of course, a systolic flow murmur. You can get hyperkinetic right ventricle and hyperkinetic left ventricle. You can get mighty displacement of the apex. You can get the other findings which are given in A, B, C, D, and you can rarely get in S4 gallop. So S4 gallop is a rare occurrence, and the diastolic murmur is a never occurrence. If you get a diastolic murmur, we are not talking, of course, about a diastolic component of a continuous murmur like the mammary souffle. But an isolated diastolic murmurs is always pathological in pregnancy. So that's an important point. It's very important for anyone taking care of pregnant women is to be acquainted with the physiological changes which occur in pregnancy. So this is a composite diagram which illustrates this very well. And if you look here on the x-axis, you have the duration of pregnancy in weeks, and on the y-axis, you have the percentage changes in the different items that I'm going to talk about in relation to the baseline measurements. So if you look into the red line here, this is the blood volume, and you get an increase of the blood volume right from the beginning of pregnancy, and it peaks towards the end of pregnancy. So it peaks in the third trimester of pregnancy. And the reason of that is activation of the renin-angiotensin-aldosterone system, particularly aldosterone, of course, because of the estrogen and progesterone secretion by the placenta. You get an earlier change in other parameters. So the stroke volume increases by 30% right from the beginning at the end of the first trimester. By that time, the woman just knows that she is pregnant. So you get an increase in the stroke volume by about 30%, and it remains in this 30% until the end of pregnancy. And you get an increase in the cardiac output by about 50%. The heart rate increases a little bit, 10 to 20 beats per minute during the second and third trimester, and it decreases immediately before pregnancy. Because of the pregnant uterus can compress the inferior vena cava, and a decreased venous return may be responsible for a decrease in the cardiac output before the end of pregnancy. But usually the cardiac output is measured in pregnant women in the left lateral position to avoid the compressing effect of the pregnant uterus. It's interesting to know that all these hemodynamic changes have been measured in the 60s, 70s, and 80s, and they have never been measured after that. So these are all the data, and this is a gap in the medical knowledge whereby the recent method of evaluation of these parameters has not been applied to pregnant women so far. The only thing which decreases in pregnancy is the systemic vascular resistance, which is the green line. In this green line, you find that peripheral vascular resistance decreases by almost 30% right from the beginning of pregnancy. This is because of the composite effect of the wide placental circulation and the wide spiral arteries of the uterus. So the uteroplacental circulation has a very low resistance, much more effective in lowering the vascular resistance than ARBs and ACE inhibitors. And at the same time, the heat produced by the developing fetus causes vasodilation, and pregnant women has a high level of prostaglandins, nitric oxide, and natriuretic peptides. So this probably is a primary factor which is responsible for increase in the other conditions like the cardiac output, stroke volume, heart rate, and the plasma volume. Obviously, the plasma volume increases out of proportion of the red cell volume, which also increases, and this produces the physiological anemia known in pregnancy. The more important point is what happens during the first 3 to 4 weeks postpartum. You get the autotransfusion of blood from the pregnant uterus and the placenta, and as a result of that, the volume of blood increases again. With each uterine contraction during labor and delivery, you get evacuation of almost 300 to 500 cc's of blood. So that's a lot. So as you see, the stress here occurs not only in the third trimester, but also in the second trimester, and any diseased heart is required to compensate for that. If the heart is able to increase the cardiac output by this degree and increase the heart rate by this degree, then this heart can tolerate the overburden of pregnancy. If it cannot, then you get some problems during pregnancy. And this is important to understand what happens in stenotic and regurgitant regions, shunts, and so forth. Now, there have been several models which illustrate the effect of pregnancy on cardiac disorders. And these several models, they have a very, very well discriminated function, separating those who can tolerate pregnancy well from those intolerable to pregnancy. There is something in statistics called C statistics. The C statistics discriminates between different variables. So this is a diagram which shows the relation between 1 minus specificity. 1 minus specificity, if you make simple calculation, indicates the false negative results against the sensitivity, which indicates essentially the true positive results. So we are comparing the false negative. False negative means that it is positive. False negative with the true positive. And as you see, this is what we call the C curves for the different variables or different scoring system, which have been published about the effect of pregnancy on heart disease. And this is what is called the area under the curve. So among the different scoring systems and risk classifying systems, the green one is on the top here. This is the WHO classification of the various classes of risk in pregnancy. So this WHO classification is one of the best because it has the so-called area under the curve larger than the other systems. So this is a little bit of statistics to explain this figure. But several models of heart risk in patients of pregnancy have been published. The most common complications, of course, arrhythmias, heart failure symptoms, and the important risk factors in different scoring systems is prior cardiovascular events. Of course, if you have prior cardiovascular events like heart failure, like serious arrhythmia, like stroke, then this is a top priority in illustrating the risk of pregnancy. Also, poor functional class, ventricular dysfunction, and left ventricular outflow tract obstruction. And nevertheless, many of these scoring systems neglected or underrepresented the effect of pulmonary hypertension and connective tissue disorders like Marfan syndrome. But we'll talk about that in detail. Now, this is the essential part of the WHO classification maternal risk system. It classifies patients into different classes, class 3 and class 4. Both of these, they should have a very cautious approach in the treatment of these women. Class 4 patients should be advised not to get pregnant, and if they get pregnant, then it's an indication of termination in the large majority of cases. Otherwise, skillful handling will be very important as a teamwork between high-risk obstetricians, anesthesiologists, neonatologists, as well as the cardiologists. Now, class 3 conditions which are notorious for having complications during pregnancy include all forms of cyanotic heart disease, mechanical valves, when the right ventricle is a systemic ventricle, as in different forms of transposition, the Fontaine circulation, which has been explained before, Marfan syndrome, particularly if the aortic dimension exceeds 40 to 45 millimeters, and bicuspid aortic valve with dilated aorta. Class 4, which should be an indication for truthful counseling of the patients to avoid pregnancy or to terminate pregnancy when it happens, is pulmonary hypertension, severe forms of ventricular dysfunction with an ejection fraction less than 30, or New York Heart Association class 3 and 4, severe symptomatic aortic stenosis, native severe coarctation, Marfan syndrome with more dilatation of the aortic root above 45 millimeters, and bicuspid aortic valve with more dilatation of the aorta more than 50 millimeters. So as you see, these risk factors are very important because they increase the maternal morbidity and mortality. The CAR bridge, this is the cardiac patients in pregnancy, number 2, has been more recently published just 2 years ago, 3 years ago. And this is a study of a registry containing more than 2,000 pregnant women with cardiac diseases. Again, replicated almost the same point, but in a scoring system. So the risk is very high in patients with previous cardiac events or arrhythmia, or baseline New York Heart Association class 3 or 4, or cyanosis, or mechanical valve. Notice that mechanical valve is even taking a higher score than pulmonary hypertension, 3 versus 2. Ventricular dysfunction, high-risk left-sided heart disease, pulmonary hypertension, coronary artery disease, high-risk aortopathy. And this scoring system is adding two important things, which are non-specific findings, like late pregnancy assessment and no prior cardiac intervention. The slide on the right side, the part of the slide on the right side is showing the same thing. And this is a confirmation of the importance of these various factors in indicating the risk of pregnancy. Now, having said that, let us move to one of the biggest problems in pregnancy, which is a major cause of pregnancy and mortality everywhere in the world. But astonishingly, it has a very wide variability in the incidence all over the world, varying from 1 to 100 pregnancies in Nigeria to 1 in 10,000 pregnancies in Denmark. We don't know exactly what's the prevalence of the condition in Egypt, but it's not uncommon. What's peripartal cardiomyopathy is defined as idiopathic cardiomyopathy presenting with heart failure secondary to left ventricular systolic dysfunction presenting towards the end of pregnancy. So there is no indication of a strict time domain. Or in the months following delivery, again, no indication of a specific duration, but it says that the several months following delivery where no other cause is found. So it's a diagnosis of exclusion. There should be no history of previous cardiac disease, and the diagnosis is confirmed by echocardiography with left ventricular ejection fraction below 45. Now, even the occurrence of Even the occurrence of postpartum cardiomyopathy shows wide variability between different geographic regions. So it's, in blue, this is antepartum occurrence during the last months of pregnancy, and green is the occurrence between the 3rd and 6th months postpartum, and violet. So as you see in South Africa, it is about 1 in 1,000, no cases have been reported antepartum. Whereas in US, about a quarter of the patients occur in the latest month of pregnancy. Obviously, there is no clarity in the prevalence of the condition markedly between different countries and the time of occurrence. At the time of occurrence. يا محمد لو سمحت الصوت.
محمد اقفل الميكروفونات على كل الناس. اريني
This slide is
مفتوح.
حاضر يا دكتور حاضر.
Now this slide is important from the etiological standpoint. Obviously, those sitting the examination shouldn't take much attention to the etiology. Usually, the questions center about the clinical presentation and treatment, not the theories behind the different etiologies. So as you see on the left side of the slide here, in normal pregnancy, you get some changes in the heart in the form of ventricular dilatations and some hypertrophy. But usually after delivery, you get normalization of these things. But because of the interference of a variety of factors, including viral infection, stress of activated cytokines, autoimmune changes, genetic changes, and excess prolactin, which I'm going to detail its story now. As a result of that, you get postpartum cardiomyopathy. In 2/3 of the patients, you get normalization of ventricular function, but still contractility is impaired. So because still contractility is impaired, there should be cautious counseling for the patients who normalize this ventricular function to get pregnant again. And I will come to that soon in more detail. And in 1/3 of the patients, you get irreversible cardiac dysfunction. And most of these patients, they get into heart failure and pregnancy or pregnancy for the second time should be contraindicated. Now, what's the story of the prolactin? As a result of pregnancy, from these different factors illustrated on the left side of the slide, you get increased prolactin secretion by the pituitary gland, and this prolactin is being split by a substance called cathepsin D. Cathepsin D split prolactin into different small molecules, which is actually toxic prolactin. And this toxic prolactin results in apoptosis, inflammatory conditions, and as well as the liberation of a variety of cytokines, which damage the myocardium and the endothelium. Meanwhile, the placenta secretes at the same time a vasoreactive growth factor, and this vasoreactive growth factor gets split again by a variety of factors into what's called soluble flat. And soluble flat is actually a toxic substance that's being liberated in preeclampsia. This is the main theory of preeclampsia, to get this molecule. And this molecule, again, is having the same hazardous effects like the toxic form of prolactin, pro-apoptotic, pro-inflammatory, and anti-angiogenesis. So it produces decrease the blood flow and the ischemia of the placenta. Remember that preeclampsia, the essential pathophysiology is that you get the spiral arteries of the uterus not remodeled to allow excess blood flow to the placenta. So as a result of that, you get placental ischemia, liberation of different cytokines, which ensures that the endothelium elevates the blood pressure and produce end-organ dysfunction. So there is a much overlap between the pathogenesis of preeclampsia and the occurrence of the peripartum cardiomyopathy. Now, in support of that, the most cases of peripartum cardiomyopathy are occurring in the first 1 to 4 weeks postpartum, and this is exactly the time when the toxic form of prolactin and the FED2 is having its peak. So during this time, in addition to the hemodynamic stress produced by the excessive blood volume and the excessive venous return due to evacuation of the uterus and the autotransfusion of blood, and the contractile function of the contractile behavior of the uterus during the labor and the delivery, these added to the mechanical effect of the increased venous return and the toxic effect resulting in apoptosis, inflammatory, and anti-angiogenesis effect of the toxic prolactin and the FED2 This results in the occurrence of postpartum cardiomyopathy in the first few weeks of a postpartum period. So the majority of patients, they present in the postpartum period, mostly during the first week after delivery. They present with heart failure symptoms, and these toxic substances are at its peak during this period, and the occurrence of the toxic prolactin and FELT2, soluble FELT2, they trigger probably this syndrome. We know that the prognosis of patients with postpartum cardiomyopathy is closely related to the ejection fraction. So this is a study from an American registry called the IPAC registry. The IPAC registry investigators, they have had published about 100% women with postpartum cardiomyopathy. They had the ejection fraction repeatedly evaluated at baseline and at the second 6 and 12 months. And they were recording during these three factors or three forms of events: death, transplantation, and the use of left ventricular assisted device. Turned out that 13% of these women, they had an event or a left ventricular ejection fraction equal or less than 35% by 1 year. And as you see on the right side of the slide here, if the ejection fraction is below 30%, then the number of events is far exceeding when the ejection, compared with the ejection fraction more than 30%. And when the left ventricular ejection fraction is less than 30%, or left ventricular end-diastolic dimension equal or more than 6 centimeters, no subject recovered. So this should be taken in serious consideration, because you will use this material in counseling female pregnant women about the possibility of a secondary pregnancy. So after the initial evaluation and confirmation of the diagnosis, you should evaluate these patients. If they are hemodynamically compromised, then you go through this pathway on the left side of the slide. If they are not hemodynamically compromised, you go to the right side pathway of the slide. This is taken from the European guidelines in 2016. If they are compromised, then you optimize everything: the preload, oxygenation, you add inotropes or vasopressors to elevate the blood pressure, and you consider bromocriptine. Bromocriptine is a dopamine agonist, and dopamine is a prolactin inhibitory substance. So bromocriptine acts in the same way. It decreases prolactin, and as a result of that, toxic prolactin, which is produced by the action of cathepsin D, will decrease, and its hazardous effects will decrease. So the time, the duration of prolactin of bromocriptine therapy is not indicated exactly. There have been several trials, but it can be given mostly for 1 week. There has been a trial which showed bromocriptine in a small dose, like 2.5 milligram BID, when given for 8 weeks, is exactly equivalent to when it's given for just 1 week. So it's a short course of bromocriptine is going to help under these circumstances. If there is no recovery, then the patients can go to transplantation. There have been several reports of successful transplantation for postpartum cardiomyopathy. If they recover, then you can wean them from ventricular assisted device. In patients who are more stable, then the treatment will differ whether they are antepartum or postpartum. And if they are antepartum, then you avoid the heart failure treatments, which are contraindicated during pregnancy, which is all the ERAS inhibitors, angiotensin receptor blockers, angiotensin receptor ACE inhibitors, and renin antagonists, and anti-aldactone or anti-aldosterone. All of these are contraindicated during the pregnancy. You can give hydralazine, which is of course not available to us, but what's available to us is nitrates and beta blockers. You can consider diuretics as well. You can consider also a short course of bromocriptine. If the patient recovers and or delivers, then you can be free to give all the traditional therapy for heart failure, including ACE, ARBs, aldactone, or spironolactones. And you can consider also bromocriptine Bromocriptine is a class B indication for pregnancy, so it's not contraindicated pregnancy, but despite that, the recommended dose is just 2.5 milligram BID. And you can consider heart failure therapy freely so long as you are postpartum and the pregnancy is over, no risk for the fetus. Now, this is an important slide which shows here in blue patients who did not recover their ejection fraction, and in contrast to patients in violet recovered their ejection fraction. So if you have patients recovering their ejection fraction, normalizing their ejection fraction in the postpartum period, there is still a possibility of more than 20% of having heart failure symptoms in the subsequent pregnancy. And they are having a decreased ejection fraction in still more than 20% of patients. And many of these patients, they get persistent left ventricular dysfunction. But fortunately, none of them die. But if they didn't recover their ejection fraction, which are the blue bars, then the possibility of having heart failure symptoms is about 50%, 44%. And the possibility of decreased ejection fraction is almost 1/4 of them. Persistent left ventricular dysfunction is about 1/3, and the mortality is horrible, 19%. So as a result of that, the American guidelines recommended that if the patient had complete recovery of the ejection fraction, then you counsel her that she's having a better prognosis in subsequent pregnancy, but still there is a possibility of 20% to have relapse. But despite that, they can have a normal pregnancy and delivery. But they should be very cognizant of the fact that 20% possibility of relapse in subsequent pregnancy. Now, the condition is very bad in patients who did not recover their ejection fraction. They have a higher incidence of relapse. They have about 50% of further deterioration of left ventricular dysfunction, and they have the possibility of premature delivery and abortion to come in subsequent pregnancy. It's very important to tell women what's going to happen to them and what's going to happen to the baby. Because many women, if you counsel them about these hazards of subsequent pregnancy, they accept it. But when they know that the baby is going to be affected, then they probably change their decision. Now, this is important for counseling. So after the general health measures that's being implemented, again, you have to find out whether the patient recovered her ejection fraction or didn't recover her ejection fraction, and the possibility that even if they recovered the ejection fraction, there is still a possibility of risk to the mother and but no risk to the baby. But if they didn't recover their ejection fraction, then the possibility is very high to have recurrent heart failure or persistent heart failure, and a risk also of fetal death, prematurity, and so on. Prematurity is a very big problem because if you have a prematurity or low birth weight less than 2.5 gram, very low birth weight is less than 1.5 kilogram. These patients are very prone to intracerebral hemorrhage. They are prone to renal failure. They are prone to mental retardation, failure of growth, and they are prone to acute respiratory distress syndrome. So it's a big problem to have a low birth weight. Now, this is a molecular study which showed that patients with polypartite cardiomyopathy, they share a lot of the gene problems in idiopathic dilated cardiomyopathy. And particularly, as we said before, the commonest gene variant in dilated cardiomyopathy is the TITIN gene. And if you have a TITIN gene mutation in patients with postpartum cardiomyopathy, which is a common occurrence, particularly in those who do not regain their ejection fraction, then the prognosis is dismal, and the possibility that they will never recover their ejection fraction is existing. Now we shift gears and now talking about arrhythmia in pregnancy. Of course, pregnancy is an arrhythmogenic situation. It triggers the pre-existing arrhythmias, and the arrhythmias may manifest for the first time. Probably the commonest thing is frequent PECs and PVCs. We treat them the same way that we treat them in absence of pregnancy. So as long as the ventricular function is normal, we just have watch them. There is an increased arrhythmia burden in combination is due to the hemodynamic, humoral, and autonomic changes. We usually use the lowest doses of the effective drugs during treatment. As we alluded before, cardioversion is safe so long as you put the pedals of the cardioverter away from the uterus as much as you can. And rarely you resort to therapeutic catheter ablation. And many of the electrophysiologists now doing this under ultrasound guidance in order to prevent radiation exposure. Supraventricular tachycardia is the most common arrhythmia in pregnancy. AVNRT requires, of course, vagal maneuver. Adenosine metoprolol is very well accepted. They are class 3 drugs that have come to this classification. They are very well tolerated during pregnancy. There is no contraindication in using them, but you have to be cautious in using drugs that block the AV conduction, like rapamil and digoxin in patients who have the suspicion of WBW, to avoid the risk of rapid accessory pathway conduction. Remember that atrial fibrillation and the atrial flutter are less common, and if they are encountered, you have to rule responsible disorders like thyroid dysfunction and pulmonary embolism. It's very rare for ventricular arrhythmias to occur in the absence of structural heart disease. So if they are encountered, you should be on the lookout for structural heart disease, and you should implement a long-term beta blocking therapy in patients who are having long QT syndrome. The fuss about the beta blocker therapy that they cause bradycardia, hypoglycemia, failure of growth retardation, it's usually exaggerated. Metoprolol is extremely safe during the pregnancy. And this is the list of drugs and their level of toxicity or risk according to the FDA. This was published in 2014. In 2015, the FDA changed its mind, and now you have very specific drug side effects for every drug. The drug during the pregnancy, during the delivery, postpartum, and for the baby during lactation. But this table is still very helpful. So as you see, most cardiovascular drugs are class C. Class C means that you have teratogenic effect in animals, but have not been reported in human beings, in contradistinction to class D or X, which are contraindicated in humans. So amiodarone you avoid. Also dronedarone are associated with vascular and limb or cleft vascular or limb abnormalities or cleft palate. But as you see, sotalol and lidocaine are very safe, and the other drugs which have been reported as teratogenic in animals, not in human, are relatively safe and should be used freely. Now we move to Marfan syndrome, a big problem during pregnancy, and this is an important study from the Genetech registry, which has been reported in 2016. They were studying 94 women with Marfan syndrome, which carried 227 pregnancies. 10% experienced pregnancy-related aortic complication, including type A dissection, type 2 dissection, coronary artery dissection, and rapid aortic growth. And the highest rate of dissection was in the immediate postpartum period. And surprisingly, 3 of the 8 women with aortic dissection were not completely aware of their diagnosis. So as you see, aortic problem is an important thing. This is the guidelines, the American guidelines, which indicates the importance of counseling patients and following aortic root dilatation in patients who are prone to dissection. So counseling about the risk of dissection and the heritable nature. This is important because, as I told you, it's important to counsel the patient about herself and about the baby. So you know that Marfan syndrome is an autosomal dominant disorder, so the possibility that the offspring will be having the disease is 50%. So counseling about the risk of aortic dissection and the heritable nature of the condition and the importance of the blood pressure control. The aortic diameter should be followed by echo measurements monthly or at least bi-monthly. And it's important to remember this figure at which you have to replace the aortic root before pregnancy if the diameter of the aorta in Marfan syndrome more than 5 centimeters. more than 4 centimeters. So this is the number which you need to remember as an indication. This is the aortic diameter before pregnancy. And the fetal delivery by cesarean section is reasonable. It's not a must. It's just a reasonable alternative for patients with significant aortic enlargement, dissection, and severe aortic regurgitation. Question 2. 30-year-old woman in the 29th week of pregnancy presents for evaluation of a murmur. She denies cardiac symptoms. Transthoracic echo reveals aortic stenosis with a P gradient of 64, that's severe aortic stenosis. Which of the following statements is true? Balloon valvuloplasty will be required prior to delivery. She should undergo urgent cesarean section. She should be anticoagulated. There is 30% chance that the infant will show low birth weight with its hazardous effects, as I just pointed out. Or she does not have an increased risk of complications during pregnancy. So the correct answer here is D. This is an important article from a registry that I will show you in a while. Of course, the possibility, this is an asymptomatic patient, denies any symptoms, so there is no place for balloon valvuloplasty. It's not an indication for cesarean section so long as it is asymptomatic. There is, of course, no indication for anticoagulation. And the correct answer that 30% of these patients will be having a low birth weight. And I will give you the data about that. So the guideline indicates that the stenotic valve lesions are not well tolerated because of the pathophysiologic changes that I illustrated in the second slide of this lecture. Is not as well tolerated as in regurgitant lesions during pregnancy. So mitral stenosis and mitral stenosis, we are hampered by the increased heart rate, which reduces the filling of the left ventricle and results in elevation of the left atrial pressure and the occurrence of pulmonary edema. And if you get vasodilatation, then in aortic stenosis, you get exaggeration of the gradient, and particularly if the cardiac output is increased, as we saw on the second slide. And this leads to increased end-diastolic pressure. So this is the study from the ROPAC investigators, a big registry in Europe, including more than 2,000 pregnant women with different forms of heart disease. They studied 96 women with aortic stenosis. 1/3 of them were having a severe aortic stenosis. And among these patients, 21% were hospitalized, but no mortality. More common in severe aortic stenosis, and the highest incidence of hospitalization was in symptomatic aortic stenosis, severe aortic stenosis. And this is the answer of the question. 35% of patients with severe aortic stenosis, they have low birth weight infants. And as I told you, this is a big problem because of the extreme morbidity in these patients. And this is a Cox diagram, which shows that the mortality rate and incidence of adverse effects is directly proportional to the symptomatic stage of the patient. So patients with advanced degree of heart failure and patients who are having severe aortic stenosis, they have increased odds of having adverse maternal outcome. So the guideline indicates that in symptomatic severe mitral stenosis, percutaneous balloon mitral commissurotomy is indicated if the valve surgery if the morphology is not favorable for the balloon business, and particularly in patients who are class 3 or 4 heart failure, symptomatic despite optimum medical therapy. And for severe aortic stenosis, valve intervention is only indicated if hemodynamic deterioration occurs or the patient is in class 3 or 4 heart failure symptoms. In patients with valvular regurgitation, whether we are talking about mitral regurgitation or aortic regurgitation, valve operation is only indicated in functional class 4 symptoms. You know that there are guidelines for valvular heart disease that have been published last month, American guidelines. Now they changed this recommendation into class 3 or 4. So class 3 or 4 symptoms or hemodynamic deterioration, this is essentially the indication for stenotic or regurgitative valves with no discrimination. Now we move to the effect of pregnancy in a very peculiar situation, very hazardous situation, which is the prosthetic heart valves. Again, going back to the ROPAX surgery, they studied 212 mechanical valves versus 134 patients with pregnant patients with bioprosthetic valves. Mechanical valve thrombosis occurred in 5% of these women. Half of them occurred in the first trimester, and all of these patients had the thrombosis, mechanical valve thrombosis at the time they switched from warfarin to heparin. This is an important point. Heparin, including unfractionated heparin as well as low molecular heparin, is a poor anticoagulant during pregnancy. In pregnancy, we have a hypercoagulable state because of increased production of all coagulation factors except factor 11 and 13. The others are having increased concentration in patients who are pregnant. There is decreased fibrinolytic enzymes. So as a result of that, you get increased coagulability, and because of that, we need strong anticoagulants. Heparin in its two known forms, unfractionated heparin and low molecular heparin, are poor anticoagulants in pregnancy. So as a result of that, you'll find that in the ROPAC registry, this study showed that at the time of the changing an anticoagulant from warfarin to heparin resulted in thrombosis in all the patients that have been studied. Obviously, hemorrhagic events are higher in women with mechanical valves versus those with prosthetic valves, and the rate of heart failure was similar, and also the mortality rate was similar. So the problem is the difference in the prosthetic valve thrombosis. So warfarin, because of its strong anticoagulant effect, is recommended in all pregnant patients with mechanical valves to achieve a therapeutic INR in the second and third trimester. We will talk about the first trimester and the last week of pregnancy soon. Warfarin should be discontinued, and with initiation of unfractionated heparin, keeping the APTT twice control or more, before planned vaginal delivery in pregnant patient with a mechanical valve, and I will detail about that because the new guidelines give a very discrete description of what should be done during the last week of pregnancy. This was very ambiguous in previous guidelines. And it's important to know that this is what we usually forget is to give a low dose aspirin once daily for pregnant women in the second and third trimester with either a mechanical or bioprosthetic valves. Anyhow, the obstetrician usually advise giving aspirin, but in a dose of 100 milligram, not 75, for prophylaxis against preeclampsia in women predisposed to preeclampsia, like obese, those of African descent, hypertensive, and so forth. So as you see here, that warfarin is a big problem, but this is one of the ways we exit from this problem, because the guideline indicates that continuation of warfarin in the first trimester of pregnancy is reasonable if the dose to achieve the therapeutic INR is equal or less than 5 milligrams per day. So if you have warfarin that's needed for proper anticoagulation less than 5, then there is no reason to shift from warfarin to heparin in its two forms. If the dose of warfarin is more than 5 milligrams per day to achieve a therapeutic INR, then you have to use dose-adjusted low molecular weight heparin. This is important. The guidelines say dose-adjusted, doesn't say weight-adjusted. If you get weight-adjusted, that's the reason you get into problem. So we don't give 1 milligram per kilogram body weight. This is called weight-adjusted. We give dose-adjusted. How can we give dose adjusted? By repeated measurements of anti-10A, keeping it in the range between 0.8 to 1.2 units per milliliter, with the sample taking 4 to 6 hours post-dose. Anti-10A is not widely available to Egypt, so we don't recommend that you using low molecular weight heparin in the first trimester instead of warfarin, except when you are having access to estimation of anti-10A because this should be repeated 2 or 3 times every week to make sure that the low molecular weight heparin is achieving its target, preventing valve thrombosis, because as I told you, it's a poor anticoagulant. If you don't have access to low molecular weight heparin and it's the dose adjustment by anti-10A elevation, then you can use dose adjusted continuous infusion, not subcutaneous, continuous infusion of unfractionated heparin aiming at an elevated prothrombin time, thromboplastin time of 2 times the control value during the first trimester. So I summarize this clearly here. If you have pregnant women with a mechanical valve, then you have to take care that the first trimester you have 3 choices. The 3 choices is either you continue warfarin if the dose of warfarin needed to keep to get a therapeutic INR is less than 5, and this is the best solution. If the dose of warfarin needed to get a therapeutic INR more than 5, then you have to choose low molecular weight heparin, dose adjusted, not weight adjusted. You have to have an access to repeated evaluation of anti-10A level. Or if this is not available, then there is no extreme risk from changing warfarin into dose adjusted intravenous infusion of unfractionated heparin. On the other hand, if the dose of warfarin is needed to keep a therapeutic INR is more than 5, then you have to use heparin, either low molecular weight heparin or unfractionated heparin, as I indicated. After the first trimester, you go into the second trimester, you use warfarin, and you continue use warfarin, achieving INR between 2 and 3 until the last week of pregnancy. Now, here is the new guideline is detailing this. So during the last week, you change it to low molecular weight heparin, or you change it to unfractionated heparin. If you use unfractionated low molecular weight heparin, you stop 36 hours before, change it into intravenous continuous infusion of unfractionated heparin until the last 6 hours, then you stop anticoagulation. So let me repeat again what happens during the last week. During the last week, you stop warfarin. Why you stop warfarin in the last week? Because if you stop, warfarin crosses the placenta and goes to the brain of the embryo. So the patient gets delivered vaginally. When he is on warfarin, he will get intracranial hemorrhage. So that's why we change into heparin. If you change into low molecular weight heparin, then you have to change this 36 hours before pregnancy into unfractionated heparin, and you stop anticoagulation before delivery by 6 hours. So therapeutic anticoagulation with frequent monitoring is mandatory in patients with mechanical valves. Unfractionated heparin is a poor anticoagulant. Same applies to low molecular weight heparin, high risk of thrombosis. And there are complications from vitamin K antagonists, which are dose dependent. You remember the 5 milligram business. And the low molecular weight heparin, if used, needs a meticulous monitoring of the anti-10A level. And you convert to unfractionated heparin prior to planned delivery in the way I detailed it just now. Now, this is a nice slide which shows the risk to the mother, the risk to the baby, and the risk to either the mother or the baby. And if you look here into the second column here, this is the safest. As you see here, if you use low dose warfarin, because this is enough to achieve a therapeutic INR, then the risk to the mother is very low, it's just 5%. The risk to the baby is equally low, and the risk to both the mother and the baby is acceptable. Now, if you move more to that, the second best is to use a combination, to use a low molecular weight heparin or a combination of low molecular weight heparin and vitamin K. But as you see here, the risk to the mother and the baby is definitely higher. So this is a nice diagram which just collects all the information that we need to know. Before I summarize, I need to talk about the other conditions with pregnancy. Unfortunately, I don't have slides for them. So one of them is obviously hypertension. We talked about that when we discussed the hypertension. We know that hypertension can come in three flavors during pregnancy. One of them is the chronic hypertension present before the 20th week. We treat it as usually, but we avoid the RAS inhibitors. Patients who are having gestational hypertension after the 20th week, and if they get proteinuria, that's preeclampsia. But remember that the definition of preeclampsia changes. You don't necessarily have to have proteinuria. You might get proteinuria or you get evidence of organ ischemia, renal failure, hepatic infection, HELP, which is elevation of hepatic enzymes plus thrombocytopenia or isolated thrombocytopenia. So any of these conditions indicates the occurrence of preeclampsia. And the third type of hypertension is a combination of chronic hypertension and gestational hypertension. Another important complication, not very common, occurs in 100,000 is occurrence of coronary artery disease. Commonest cause of coronary artery disease during pregnancy is dissection. The second, third, and fourth complications, etiology is usually isolated thrombosis or coronary spasm, and rarely atherosclerosis. But as you know, atherosclerosis is becoming more prominent because many of the pregnant ladies are now elderly, many of them are smokers, many of them are obese, with hypercholesterolemia, and so forth. So that predisposes them to the occurrence of atherosclerosis. Remember, many of the recent reproductive technology like hyperstimulation syndrome or are making women get pregnant above the age of 40. The ovarian hyperstimulation syndrome is associated with 100 times the risk of deep vein thrombosis. So giving intensive hormonal therapy can result in a lot of problems, and therefore it's expected that the occurrence of thrombosis and coronary atherosclerosis and thrombosis is going to be on the rise. Another subject that I need to emphasize is the occurrence of occurrence of pregnancy in patients with congenital heart disease. Left to right shunt is very easy to be handled, well tolerated unless Eisenmenger can occur. We have problems, of course, with cyanotic congenital heart disease. Usually it's a contraindication to pregnancy. It should be fixed before pregnancy. You can get thrombosis, you can get paradoxical embolism, you can get intensification of cyanosis because of the increased right to left shunt as a result of the peripheral vasodilatation. Many of these patients need to be anticoagulated. But if they get pregnant, then it's important to notice that these patients should avoid vasodilator anesthesia. They should have rest in bed. They should be anticoagulated in the last months of pregnancy. In the discussion, we can detail about that. Patients with hypertrophic cardiomyopathy, they tolerate pregnancy well, although we have peripheral vasodilatation, which should augment the gradient of the obstruction, but still the hypervolemia can antagonize this. But the patients usually need an increase in the beta blocker dose, avoiding epidural and spinal anesthesia, avoiding any hypotensive measures, and avoiding, of course, positive inotropic agents. So to summarize this situation, there are some dramatic hemodynamic changes that occur during pregnancy. Most forms of cardiac disease do not preclude pregnancy. In the past, there was an Italian paradigm which says that if you have heart disease, don't fall in love. If you fall in love, don't make love. If you make love, don't get pregnant. If you get pregnant, don't have babies. Now, this is outdated, and as you see, most forms of heart disease can tolerate, these patients can tolerate pregnancy well. But some of them, they pose increased risk, particularly the mechanical bed. The established risk factors for adverse maternal outcome include prior cardiac events at the top of the list, poor functional class, central cyanosis, ventricular dysfunction, left ventricular outflow tract obstruction, particularly aortic stenosis, symptomatic severe aortic stenosis, mechanical valves, pulmonary hypertension, and aortic root dilatation. Women with heart valve disease require special attention and close cooperation between very large number of other specialties like obstetricians, anesthesiologists, neonatologists, and so forth. So thank you very much, and I wish you have some questions so I can answer them. I will try. محمد باشا.
دكتور محمد، انا وحضرتك.
يا ناس.
اول سؤال بيسأل عن الهيبرين. before delivery ممكن ندي الهيبرين subcutaneous instead of intravenous?
No. Heparin should be given intravenous. Subcutaneous, you get erratic absorption. These patients sitting having edema all over, and the absorption is erratic, so you cannot guarantee that they will be in therapeutic index. Even if you give it intravenously, the therapeutic effect is usually fluctuating, and we know that it's a not very effective anticoagulant, so should be appropriately administered in the way the guidelines indicate.
اوكي. في سؤال تاني بيسأل على ال indication of pregnancy termination because of a cardiovascular condition.
Indications of pregnancy termination: number one, if there is an obstetric indication like contracted pelvis or placenta previa, obviously this is left for the obstetrician to indicate. Number two, if the patient is is on anticoagulation, particularly warfarin. So these patients, we are afraid of having a remodeling of the skull during vaginal delivery, so they get intracranial hemorrhage. Number three, any hemodynamically significant cardiac condition, including severe heart failure, severe aortic stenosis, Marfan syndrome, or any form of aortopathies, pulmonary hypertension. So these kind of things, they are completely contraindication to vaginal delivery. And so, but you have to have a discussion in a team form to make sure that the patient understands it with participation of the patient. But these are the textbook contraindication to vaginal delivery, but they are negotiable in the large majority of them.
سؤال تاني بيسأل عن المود اوف ديليفري vaginal versus cesarean section in different cardiovascular conditions.
احنا اتكلمنا اهو. هو نفس السؤال. Cesarean section, again, cesarean section for obstetric regions in the large majority of cases. يعني ده المين indication. عندها حاجة ما تخليهاش تولد. Obviously من الحاجات اللي هي تهمنا diabetic babies. Diabetic babies, they get shoulder dystocia. They get, as a result of the macrosomia, they are overweight, and one of the problems of them is shoulder dystocia. So this is an obstetric indication. We are not going to let the obstetrician, we are not going to tell them how to deliver the baby. This is unethical. So this is the main indication. Anticoagulation, severe hemodynamic disturbance, whatever you think of. Don't forget aortopathies, don't forget pulmonary hypertension, don't forget cyanotic congenital heart disease, and don't forget patients who are in hemodynamic precarious condition, like, for example, severe symptomatic aortic stenosis. But we don't usually volunteer to give cesarean section for any person. But the final word is going to be the obstetrician word. You don't tell the anesthesiologist to do his craft, how to do his craft. You don't tell the obstetrician how to deliver the baby. You just suggest for them, I think this patient is having a precarious congenital cyanotic heart disease, and it will be very valuable if you can deliver the baby by cesarean section. Not more than that.
اوكي. في سؤال بيسأل على المود اوف anesthesia in pregnant females.
Again, this is left for the anesthesiologist, but we suggest to the anesthesiologist to avoid anesthesia which is producing vasodilatation, like epidural or low spinal anesthesia in patients with right to left shunt with pulmonary hypertension, Eisenmenger syndrome, and in patients with hypertrophic cardiomyopathy. But as I told you, this is left for the anesthesiologist. Don't fight with the anesthesiologist by the way he is trying to anesthetize the patient. But this is what we think to be appropriate.
Okay. سؤال بيسأل why should we give anticoagulation with bromocriptine in case of peripartum cardiomyopathy?
Because prolactin is a thrombus scavenger. It's an antithrombotic hormone, and because if you block the production of prolactin from the pituitary, then as a result of that, thrombosis occurs. So this thrombosis is being combated by a week or so of anticoagulation. As I told you, the studies are divergent. What is the duration, the optimum duration of giving a prolactin? This is an area of active research. And there is an article which says that 1 week of 2.5 milligram BID is equivalent to 8 weeks. But anyhow, if you give prolactin, you give anticoagulants.
اوكي، سؤال برضو على البريبارتم كارديوميوباثي بيسأل عن what about breastfeeding؟
breastfeeding ماله؟
في البريبارتم كارديوميوباثي هيبقى في breastfeeding ولا لا؟
breastfeeding, there is no problem in breastfeeding. All the 99% of the cardiovascular drugs, they are excreted in milk, but they are not hazardous to the baby. So long as the patient is not in advanced heart failure and she can feed, then breastfeeding is allowed. We have no cardiac contraindication to that, except when the patient is functional class 3 and 4, and she is being in a general bad shape, then there is no contraindication for breastfeeding. Most of the drugs on the cardiovascular system are safe for breastfeeding.
حتى البيتا بلوكر يا بيه؟
حتى البيتا بلوكر. بيتا بلوكرز are very safe drugs. حكاية إن هايبوغلايسيميا أو فيتال براديكارديا أو إن هو low birth weight أو growth retardation, these are very rare. The drug is very safe and can be given freely, and even in certain patients like hypertrophic cardiomyopathy, you can double the dose to get a low gradient or get the diminished increase in the gradient during effort. So there is nothing with beta blocker.
اوكي، سؤال برضو تاني بيسأل على البريست فيدنج، هو بيسألوا ان البروموكريبتين والستوب بريست فيدنج.
Bromocriptine is given for 1 week. Bromocriptine is not given for a prolonged period. Bromocriptine is given for 1 week. We give a short course of bromocriptine. Remember, in that based on animal study, there is no large this is an area of active research. انك انت تعرف what's the optimum duration of giving bromocriptine. So we give it for a short course of bromocriptine.
اوكي، في سؤال بيسأل عن
Of course, it has side effects. Any dopamine agonist, we use the commonest reason for giving a dopamine agonist is Parkinsonism. If you ask these patients, it produces nausea and vomiting and the dizziness and the sleepiness. There is another condition called the restless leg syndrome. The treatment is dopamine agonist. It has considerable side effects. That's why we don't want to exaggerate the patient's feeling of nausea and vomiting during pregnancy and in the postpartum period by giving a longer course of bromocriptine. So 1 week is equal to 8 weeks, so give 1 week. ايوه يا دكتور محمد. الو.
ايوه يا دكتور محمد، سؤال بيسأل عن البريفيرد دراج تو ترمينيت سوبرا فنتريكولار تاكيكارديا ان بريجنسي، وهل الفراباميل سيف ولا لا؟
الايه براباميل؟ Adenosine is safe, verapamil is safe, beta blocker is safe, vagal maneuver is safe, DC shock is safe. But remember that if the patient is hemodynamically stable, most of this arrhythmia they disappear spontaneously. ده زي الاتريال فايبريليشن، نخش الاتريال فايبريليشن عندكم وتبقى كل واحد متلعبك. Recent onset atrial fibrillation, if it's hemodynamically tolerable, you leave the patient alone, it disappears. If it's recent onset. Same, this is a recent onset supraventricular tachycardia because of the hemodynamic. If the patient rests and make a Valsalva maneuver, it's going to disappear. If it doesn't disappear and you have adenosine, give it. If you don't have adenosine, you have verapamil, you have deltiazem, You have beta blocker, give it, no problem. But adenosine is 100% effect. If adenosine doesn't terminate supraventricular tachycardia, the differential diagnosis is one of two things. It's not supraventricular tachycardia, or the line is infiltrated, مخروق.
يمكن السؤال كمان بيتطرق مش بس للترمينيشن باي انترافينوس، لكن فور ذا مينتننس دوز، لان في ناس كتير بتخاف تحط البريجننت وومن على الانتي اريزميك دراجز سواء كان كالسيوم شانل او بيتا بلوكر ليتر اون.
إذا كانت العيانة بيجي لها recurrent supraventricular tachycardia, but usually they get short paroxysms of ventricular tachycardia related to effort, related to anxiety, related to drinking coffee ولا حاجات زي كده بره الكحول إلى آخره. لكن usually they are short paroxysms. يعني أنا ما شفتش ولا عيانة pregnant عندها recurrent supraventricular tachycardia محتاجة إنها تبقى إلا لو عندها supraventricular tachycardia قبل pregnancy. في الحالة دي هي if it is detected it should be treated. We know still إن هو supraventricular tachycardia requires a slow pathway ablation class 1 recommendation. So if it's resistant to drugs pre-pregnancy, then should undergo electrophysiologic termination of. If it is recurrent and the patient doesn't want to take medication, there is no contraindication for ablation for supraventricular tachycardia, provided that the irradiation time is short or the operator is capable to be guided by ultrasound.
في سؤال بيسأل عن السوتالول. Can we start Sotalol in outpatient clinic or it should be in hospital?
Sotalol should be started in the hospital. No doubt about it. There is 4% occurrence of prolonged QT interval should be in. But fortunately, Sotalol is different from the Fetalol. Sotalol usually prolonged QT interval occurs within 4 hours, not 3 days. You don't need to admit the patient except the emergency department for 4 hours. Like in the Fetalide, you have to admit the patient to the hospital for 3 days. الفيتولايد بره لازم يكون عندك شهاده من الشركه المنتجه انك انت you are capable of administering the fetolide. So fortunately it's not present in here. And as you remember, I told you في الارrhythmia lectures that it has been removed from the treatment of atrial fibrillation by the European guidelines.
تمام اوكي كده الأسئلة اللي جت خلصت.
Okay, so next time will be next Friday. نتكلم على موضوع extremely important برضو في overlap between us and different subspecialties زي pregnancy وهو cardiac patients for non-cardiac surgery. And then we will drop 1 week and then we have 5 lectures for the evaluation of the cardiac patients, including exercise test 1 lecture, nuclear study 1 lecture, CT and MRI, and then we will be closing by an important old subject, which is the mastermind of cardiology, hemodynamic monitoring. Okay, شكرا جزيلا.
اوكي شكرا دكتور محمد.
شكرا دكتور وفاء.